So now we get into specific types of medications, and we're going to start with, again, probably one of the more common things that we're obviously going to see in a sports medicine setting is drugs to treat pain, more specifically non-opioid analgesics and anesthetics. So we're going to be looking at non-opioid pain medications, the mechanisms of actions, and how they work. So first, we're going to look at pain and the biopsychosocial model. So as you know, we talk about this in our therapeutic modalities class. We actually talk about it probably in multiple classes in sports medicine setting. Pain is going to be one of the more common things that we're going to see. Actually, from an orthopedic standpoint, it's going to be a part of pretty much everything that we kind of treat. So we need to look at the complexity that kind of surrounds pain and kind of understand the full pain experience. So again, pain is the subjective, unpleasant experience associated with tissue damage. So again, I think that's a key thing. It's subjective. So again, how one person, let's even, again, looking at injuries, how one person perceives pain from a certain type of injury could be very different from how another person with the same injury perceives that particular type of pain. So there is that subjective component to it that we have to understand, and we have to know how our patients kind of perceive the pain that they're experiencing. So again, this is going to be one of the most frequent reasons for healthcare provider visits or taking medications. And again, the treatment's going to depend upon many different factors. So looking at the biopsychosocial model. So this is kind of an important way to sort of look at the various aspects of pain. So it's when we look at the biopsychosocial model, the development of illness through interaction of biological, psychological, and social factors. And as we go through this, you can kind of see and understand, from just, if you've been injured before, which again, most people experience some sort of pain at some point in their life, gives you a really good idea as to how individuals sort of perceive or sort of how they kind of get their pain experience. So biological factors are going to be, if we think of things like just genetic factors, biochemical factors. So for instance, in therapeutic modalities, we talk about, like, for instance, chemicals that get released during an injury that cause pain. So those are biological things. People have specific genes and predisposing factors that could potentially affect their pain threshold. So those are kind of the biological things that we look at. The psychological factors, so mood, personality, different emotions can affect how the pain we experience is. If you've ever had pain and you're not quite sure why that pain's there, that could sometimes sort of make it worse. We have sometimes a tendency to think that when we have pain or discomfort, if we don't know why it's happening, we sometimes, sort of jump to conclusions. I'm sure we've all kind of done this at some point where we think it's the worst possible thing, and that makes the pain worse. Then you go to the doc, you go to a physician, you find out that, it's something not as serious, and all of a sudden the pain's not as bad. So that is the psychological aspect of it, and that's a real thing. And then you have social factors, and that's just the response of other people kind of in your social circle, whether that's family members, teammates, individuals on a sports team, whoever it may be. It's kind of their response and how that impacts you. So, individuals who have a very good support system tend to, kind of deal with their pain a lot better than those that maybe don't have that same good support system. So these are all kind of things regarding pain. So pain is a pretty complex thing. It's not as simple as, well, in the case of what we tend to deal with in sports medicine, they have an ankle sprain, and then this is going to be the pain experience from that. It can vary slightly from person to person. So now we have to look at the differentiation of pain, and by that we mean a couple different things. Number one is kind of classifying our pain symptoms is going to be very important, and this is sometimes where we get into then differentiating between acute versus chronic pain. So, and again, it is possible to experience both acute and chronic pain at the same time, but kind of differentiating is going to be, and sometimes it'll be easy to differentiate. So on the next slide, we're going to discuss some of the differences between acute and chronic pain, but it is possible to experience both at the same time, but it's going to be very important how we deal with pain, and typical protocols will vary based upon whether the person's having an acute pain experience or a chronic pain experience. So in looking at acute pain, so acute pain is that sudden onset. It's typically it should last for a short amount of time, and again, part of that is the reason, we'll talk about why we experience pain in an acute fashion. So it's defined as again, lasting a short amount of time, less than 6 months. It's going to be typically linked to a specific event. So an individual who has acute pain will usually be able to tell you what happened, and I'm only saying usually because sometimes people do hurt themselves and maybe don't even realize it, but it could still be acute pain. Most patients can control this with over-the-counter medications, and again, we'll be discussing over-the-counter medications in here that are commonly used to treat and deal with acute pain. And this presents in various ways. So sharp, shooting are typical ways that acute pain. We do have dull up here. Dull is many times usually associated with chronic pain, but sometimes, again, people's pain experience can vary widely with this. Chronic pain, as we said, there's no biological value for which cure may be unlikely. So what we're looking at here is pain. Chronic pain is usually prolonged. It lasts several months. And this type of pain can be a little bit more frustrating to treat because many times we really don't know what's going on. Acute pain has a very specific biologic value. It tells us that there's something wrong. Chronic pain doesn't necessarily tell us that. One of the things that, chronic pain becomes very debilitating because it could affect ADLs and just kind of impedes a person's ability to kind of appreciate life. A lot of times, just an individual's ability to maintain social circles and things like that can really be significantly impacted by the presence of chronic pain. So again, when we're looking at dealing with acute versus chronic pain, many times chronic pain can certainly present a challenge to individuals in treating and managing it. So that takes us to the pathophysiology of pain, and some of this was actually discussed even, in some of your other classes. Again, therapeutic modalities, we talk a lot about pain, pathophysiology of pain. So some of this should sound very familiar as far as the pathophysiology of pain. So again, just kind of understanding the pathophysiology of pain interaction. So it's basically a combination of systems involved in pain. So we obviously have the nervous system, the peripheral nervous system, and central nervous system is involved in the pathophysiology of pain. We also have the immune system as well. So all of that kind of works together and kind of what turns into this expression of pain. And we'll essentially, for the purpose of this class, be looking at 3 classes of pain. So first is just the first class of pain. The first of the 3 is basically looking at nociceptive pain, and that can be either somatic or visceral pain. So somatic just being structural pain, visceral pain looking at the abdominal organs within the body, whereas the somatic just kind of focuses a little bit more on musculoskeletal. So if we're looking at musculoskeletal, typically you're looking at what is classically defined when you have a musculoskeletal injury: sharp, throbbing, kind of possibly aching, maybe even referred pain. We talk about what referred pain is. In other words, when someone's experiencing pain at a site distant from the injury. And again, pain pathways, for instance, particularly with musculoskeletal pain, a lot of these pain pathways can be managed even with local anesthetics or even stronger drugs. So again, we're going to be talking about a variety of different pain medications. Really important with nociceptive pain, again, it's acting as a protective signal to let us know that something is wrong. And again, this is what kind of tells us that there's trauma or an issue with a certain region of the body. Then you have inflammatory pain. So again, this activates the immune system via either injury or infection. So again, we kind of talked about the inflammatory process as it relates to a musculoskeletal injury. It's a similar procedure for an infection. There's similar cells involved and things like that, but it does work slightly different when we're talking an infection. But either way, you're dealing with an inflammatory response. And inflammation is basically there to just kind of discourage physical contact movement. So one thing we'll see with in the inflammatory cause of pain, again, increased sensory sensitivity after tissue damage. So if you do have tissue that gets damaged, it is a little bit more sensitive. Some of that is because of for instance, the chemical mediators that get released into the area. Adaptive pain hypersensitivity or tenderness, this is going to help just promote recovery. So again, the idea here is and then we look to control inflammation, we need to be mindful of when inflammation is either not controlled or severe injury, or in the case of certain conditions. So like, for instance, ongoing inflammation with conditions, your book gives the example of rheumatoid arthritis and how damaging it is to the body. So inflammation inherently is something that the body does need to go through when it's trying to heal itself, whether from an infection or an injury, but we have to be mindful of the fact that prolonged inflammation, or if an individual has a condition that causes just kind of like this inflammatory state in the body, that's something that obviously needs to be dealt with. And then we have pathological pain. So again, this is like pain that isn't protective, but it's just kind of harmful and maladaptive. It's not a specific symptom. It's just more or less a disease state, particularly of the nervous system. So if we look at different types of pathological pain, so again, it could occur for various reasons. So for instance, if there actually is damage to the nervous system, what we would call neuropathic pain, which again indicates that there's some sort of damage to the nervous system. Again, states where we do have like prolonged or inflammation not necessarily related to an injury or that immediate response, which would just be dysfunctional pain. There's dysesthesia, which is just like that shooting, burning pain, which usually indicates damage to a peripheral nerve. There's also something called allodynia, which is just hurting pain from light touch, and you could also have that with a nerve injury. So dysfunctional pain is very commonly associated with a lot of other syndromes and conditions. So some things that aren't necessarily acute orthopedic injuries. So there's some example of those given, like things like fibromyalgia, irritable bowel syndrome, complex regional pain syndrome. These are all kind of like pathological classifications of pain. In other words, there's not like direct damage sometimes necessarily to the body, or there's just prolonged pain associated with some other type of dysfunction when we're looking at pathological pain. So essentially the way we treat pain is through analgesics. So again, these are going to act in various ways on the peripheral and central nervous system. So much like the physical agents that we use in sports medicine settings, from a medication standpoint, these kind of operate the same way. They're basically looking to block or inhibit pain in various ways through the nervous system. And there's going to be three kind of broad categories. So there's the non-opioid analgesic drugs. So these are drugs that they're not classified as opioids. Probably the most common one we see with this is acetaminophen, or what would be your brand name Tylenol, would be one of the brand names which we're probably all familiar with. There's the non-steroidal anti-inflammatory drugs, which we're actually going to talk about in a different chapter. So we're not going to discuss these in depth here. We're going to have a whole other chapter that kind of deal with both steroidal and non-steroidal anti-inflammatory drugs. So a very common example of this would be ibuprofen, or your name, if I'm going to give a name brand, Advil. They're non-steroidal anti-inflammatory drugs. So both of these types of drugs deal with pain in different ways. And then obviously you have your opioid drugs, which we're going to talk about in the next chapter. These are drugs like morphine and oxycodone. Again, these drugs are going to be a little different from anesthetics, which have a more temporary effect, or in some cases just completely eliminate sensation. So in anesthetics can either be general anesthetics versus local anesthetics, and we'll talk about the difference between those. So again, there's a difference between an analgesic and an anesthetic. Yes, they both look to reduce pain, but it's through a different mechanism. So one of the most common analgesic drugs utilized is acetaminophen. It's used both as an analgesic and an antipyretic. So an antipyretic means that it is used to treat fever, help reduce fever. It's actually recommended for individuals of all ages, if someone does have a fever, that they can take acetaminophen, and we'll talk about why, particularly in children, sometimes it's more recommended to give them acetaminophen. It should be noted again, so acetaminophen is not an anti-inflammatory. Tylenol is not an anti-inflammatory. It is a pain-relieving drug, and we'll talk about the mechanisms by which it does treat pain. It tends to be tolerated better than aspirin. So aspirin has anticoagulant properties, which could be problematic in some instances. So the way it's going to treat pain, so again, it's not an anti-inflammatory. So yeah, you could even use it to treat arthritis, but it's not going to treat the inflammation associated with it. So the pain, the decrease through pain comes through activating the descending serotonergic inhibitory pathways in the central nervous system. So all of the pain relief aspects of acetaminophen strictly comes from what it does to reduce pain at the central nervous system through this mechanism. Even in the treatment of fever, it also works at the central nervous system. So the reduction in fever is produced from inhibition of the hypothalamus in the heat regulating centers. So again, there's no anti-inflammatory properties associated with acetaminophen. It's all through the activation of the nervous system. So, and again, it's really important to make sure that when you're giving somebody acetaminophen, that they make sure they take it obviously in appropriate dosages and whatnot, because that's going to be particularly important as it relates to the liver toxicity, which I'm going to get into here in a little bit. So it gets absorbed in the small intestine and is metabolized at the liver. The maximum dose is going to be about 4 kilograms a day. Excess could cause liver failure. So this is one of the things that you want to be aware of. You want to make sure that you don't get the additive effect. So make sure that individuals don't take multiple medications with acetaminophen in it. So, you know, for instance, many cold medications have the combination of say like a cough suppressant and a pain relieving drug, which many times is acetaminophen. So you want to make sure that if they are taking something, you know, caution them that if they're taking something with acetaminophen, not to take, you know, more than one product with acetaminophen, because then you could get closer and closer to kind of exceeding that maximum dosage. So really important to look at that. Another thing to note is that it is excreted by the kidneys. So the excretion or the elimination, much like many drugs, is going to come from the kidneys. Another thing to note about absorption, caffeine does accelerate the absorption of acetaminophen and slows excretion. This is part of the reason why a lot of times, sometimes analgesic drugs will include caffeine in them. So some headache medications will not only have acetaminophen, but they'll also have caffeine. And the absorption of Tylenol doesn't, or acetaminophen rather, doesn't seem to be affected by food consumption. So that's important as well. It's available, the strength dose, and some of this information is going to be more relevant for certain drugs. So if I give you like strengths and dosages, really important to know that. So it's available in 325 and 500 milligram doses. Typically has a half-life of about 1.5 to 3 hours. Again, the 4,000 milligram max is going to be what you're going to be looking to take per day. The recommended safe dosage being a little closer to 3,250. So as you start to exceed that, it does get to be potential for liver damage. As a matter of fact, that's one of the more common complications with that acetaminophen is individuals taking too much and causing damage to the liver. So indications and precautions. So again, I kind of talked about some things already. So again, acetaminophen is a popular drug taken with other medications, and there's certainly a lot of different medications that it can be combined with. It's really important to make sure, as I had talked about, particularly with over-the-counter medications, that if a patient is going to or is taking an over-the-counter medication for, say, something like cold symptoms, that they're aware of what all the ingredients are. So they don't want to take, again, they don't want to take a separate acetaminophen if they're already taking acetaminophen in a cold medication, okay? Because again, that could kind of create that additive effect and potentially end up giving them that hepatotoxicity and damage to their liver. So really important to make sure that they don't do that. Some other complications that are sometimes seen with acetaminophen. There is reports actually of asthma sensitivity to acetaminophen. So some people that are and again, aspirin and acetaminophen definitely work through different ways, but some individuals who are aspirin sensitive asthmatics sometimes have the same responses to acetaminophen. And sometimes there could be complications to acetaminophen use during pregnancy. So that's also another thing to be aware of. So those are some precautions you want to make sure of. So make sure, again, one of the biggest safety issues, though, as well as, again, the liver toxicity, which I talked about. So if individuals do have hepatic disease, they may want to be aware of that or potentially choose another medication. So despite some of these things, and again, despite the fears, again, as long as it's taken with proper dosages, acetaminophen is a very safe drug to take. The C table 7.1 kind of talks about kind of summarizes, and you'll kind of see this throughout these chapters where we now talk about specific medications. It kind of will summarize the pharmacodynamics and pharmacokinetics of what goes on with your analgesics. So now looking at our other group of pain relieving medications known as local anesthetics. So they're known through the suffix canes. The first local anesthetic discovered was actually cocaine, coming from the cocoa shrub. Now we know over time that cocaine is a drug that's been misused and abused. So we basically then came up with synthetic versions of this. So a lot of the different types of medications that we use as local anesthetics, for instance, lidocaine being one of the more popular ones, now are basically synthetic versions of that first discovered medication. So again, basically what you're looking to get is short-term pain relief whenever you apply this medication to the mucous membranes in the skin. Basically what you're going to see is a rapid onset. There's multiple routes of administration. So we'll talk about, you have injections and you have patches and topical applications of anesthetics. The idea is to get it to cross the various layers of the epidermis, which is that outermost layer of the skin, so that it could essentially end up reaching the target fibers, which would be your A delta and C fibers in the epidermis. So that's what you're basically looking for them to essentially target. Basically what you're going to get as local anesthetics do their job, first the sensation of pain will disappear, followed by loss, over time then, followed by sensations of temperature, touch, deep pressure, and then finally at the end, motor function. As far as some, there's one concern with anesthetics is what's known as local anesthetic systemic toxicity. This is a significant adverse effect that could potentially occur. This toxicity risk is low with anesthetics due to how fast it's absorbed into the circulation. However, this is a potential adverse effect that could happen. The symptoms of this, so this would be important to know. Have things such as, obviously, you would have perioral numbness, tinnitus, agitation, dysarthria, and confusion are some of the things that individuals will experience with local anesthetic systemic toxicity. So this is basically a systemic toxic effect due to the way the anesthetic gets absorbed. The onset of duration for local anesthetics is about a half hour to 4 hours, just based on the medication. There are some specific applications of this in sports medicine. So for instance, like a lot of times sports medicine physicians will utilize local anesthetics to help in the diagnosis of some conditions. So the book gives the example of what's called an os trigonum, which is a small bone that could develop in the posterior lateral ankle. Many times what individuals will do is, if they have an os trigonum, physician will give an injection of a local anesthetic into the ankle joint, and if the pain goes away, that helps with the diagnosis of that. So sometimes anesthetics will be used in the diagnosis of some conditions, basically trying to eliminate certain tissues from the differential diagnosis. And I direct you to 7.2. This kind of gives you, number one, it gives you some different applications of anesthetics and gives some different onsets and durations. So take a look at that in conjunction with some of the information we're going to be talking about next. So again, looking at the mechanism of action, if we're looking at local anesthetics, again, they're going to act at the cell membrane. So again, we're basically looking at nerve cell membranes, and they're basically looking to prevent the conduction of nerve impulses. So they're going to bind to the receptor sites in the nerve cell membranes, block sodium channels, and then that's going to reverse the action potential of the nerve. So effectively, basically blocking the action potentials responsible for nerve conduction. So, and a local anesthetic can impact both sensory. So this is what we were getting at before. Now, typically we want to affect sensory, we don't want to affect motor, so that's why we want to make sure, of course, through proper usage, that we're not, causing motor paralysis with a local anesthetic. The idea is, clinically, when we're using these, we want to make sure that they're blocking sensory receptors, and that's the idea when we're using them. We do know that, obviously the effects of anesthetics are obviously reversible, and nerve function recovers with no real damage to the nerve cells in most clinical applications. So just some examples of some different local anesthetics. So Procaine has a very short duration of action. That's one of the local anesthetics. It is a very, again, limited duration of action. It's quickly to get metabolized. Lidocaine has a little bit longer. It's more resistant to clearance in the body, so there is a little bit more of a longer duration of action with lidocaine. And then benzocaine, which is poorly water soluble. Benzocaine is only used topically. So while the other two can be used for injection purposes, benzocaine can only be used topically. So your routes of administration, which we already talked about, so injection, topical, and transdermal patches. So again, they all have, risks and benefits. We had talked about in the chapter on drug delivery, kind of the pluses and minuses to all your different types of routes of administration. So when we talk about injection, again, we look at the chemical structure of the canes is going to be important here. So for instance, again, we had talked about how Procaine quickly metabolizes in the bloodstream and is much shorter acting, as opposed to lidocaine, which is a little bit longer in duration. So it's going to be important when you're kind of looking at from an injection standpoint. So again, the practitioner is going to make sure that they kind of look at how long they're going to basically need the medication for, when basically trying to decide, how long they actually need the anesthetic effect to be taking place for. If we look at the topical routes, so again, we're basically looking to either numb or maybe reduce sensation within a painful area. So the key thing here is we have to cross the stratum corneum, which is a part of the epidermis, and basically be able to access the nociceptors within the skin. Okay, so it's very convenient. However, it doesn't penetrate quite as deeply as transdermal prescription. So as opposed to, like, for instance, a transdermal patch, it doesn't penetrate quite as deep, and you tend to have lower serum levels of the actual medication. There's also ophthalmic drops. Pontocaine or tetracaine is a formulation for eyes. So if there's mild to moderate eye pain, that would be something where an ophthalmic drop with an anesthetic would be applied. Okay, and then obviously for the skin, there's various creams, gels, and ointments that can be utilized. Your adverse effects related to topical, much like you would have with many things, skin irritation, burning, dermatitis, pruritus, and rash is also something else that could happen, but is less common as it relates to topical application. So another route we look at here for administration of a local anesthetic is through transdermal prescription patches. So the most common formulation of this is through basically a 5% lidocaine, which could deliver up to 12 hours of local pain relief. This is also a very common complement to oral medications related to treating pain. The systemic absorption of this is very minimal when it gets delivered, but it can basically help to relieve a lot of pain. The FDA has actually approved this to treat neuropathic pain and post-herpetic neuralgia, so that's another application for this. And again, it's very common in sports medicine settings in both acute and chronic conditions. The other thing that a patch can do is potentially prevent allodynia. So and that's because the patch itself could actually serve as a mechanical barrier for pain relief. And you want to basically do a 12 hours on off. The analgesia is usually experienced within 30 minutes with minimal adverse effects. And basically what the lidocaine patch is essentially going to do is, again, reduce ectopic transmission of the pain signals to the dorsal horn of the spinal cord. So it's going to interrupt pain signals at the sodium channels in the nervous system and the peripheral nociceptors in a localized area. So they're directly looking to, as they get absorbed through the skin, they act at the actual nerve cells, and in particular block pain at the dorsal horn of the spinal cord. For non-sports medicine considerations, again, you want to make sure that you use caution, particularly with patients with liver or kidney impairments, and the patches can be used to deliver both opioids or fentanyl as well, if need be. So if we look now at the other topical analgesics, so again, various creams, gels, and ointments. So over-the-counter topical analgesics that will produce numbing and reduce sensation. So they basically have a chemical makeup, usually combining menthol and lidocaine. So some of your over-the-counter patches that you can get, for instance, will have maybe 4% lidocaine, so they won't be quite as strong as the prescription ones. Again, you're basically still looking to affect the nervous system the same way with these particular patches. There's also topical counter irritants. So menthol and capsaicin are popular active ingredients in a lot of your over-the-counter pain relieving creams. And creams, gels, they come in all different forms. Menthol has been around for quite a while. It's a very fast-acting pain relief topical agent, helps to facilitate a decrease in blood flow. It again kind of just helps to desensitize the C fibers. Menthol also produces that like tingling sensation. So if you've ever used a menthol-based pain relieving gel or cream, you notice you get that tingling sensation, and that is going to also be something that kind of interferes with the pain signal. Capsaicin actually comes from chili peppers, and that's used in a lot of medicated creams to relieve various types of pain. Though with those you get a little bit more of like that heating effect. So if you've ever used a topical pain relief cream or gel or ointment where you get that like sensation of heat, what that does is actually helps to reduce the amount of substance P, which is a chemical pain messenger in the body, and again kind of acts almost as like a sensation that kind of overrides the pain signal that you're getting. So there's the take-home point for this is for a lot of the over-the-counter stuff. Again, there's various things out there. The patient should be aware of what type of ingredients are in it to understand the effect they're getting. So all of them will have all of these will have slightly different effects on the body. They'll all relieve pain. Now, some things may be more effective for certain individuals than others, so they may have to try different types. In other words, somebody might not get a great effect with a topical counter irritant like capsaicin, but they might feel better with maybe an over-the-counter lidocaine patch. So again, these are different. So they're all topical analgesics, but they work they do work differently. So you should know the difference between the counter irritants versus the ones that will contain the actual anesthetics in them, like the lidocaine patches do. So table 7.3 actually has a lot of the transdermal and topical analgesic clinical applications that are available over the counter. And these are ones that we're all pretty familiar with. So Salon Pause, Aspercreme, Icy Hot, Flexol. These are now, they're not all the same thing. They don't all have the same mechanism. So for instance, Salon Pause uses menthol and methyl salicylate within it. It's a transdermal patch. It's also available in gels and creams. Tiger Balm is a classic like counter irritant, and that has capsaicin in it. So be familiar with those different ingredients and kind of understanding how those different things get classified. So to look at the athletic trainer's role in the clinical management of pain. So we know that we deal with painful conditions, how we can kind of manage that. Again, provide patient-centered pain management decisions, I think is important to look at this. So, include the patient, in the decision-making process. And again, pain is a very subjective response. And again, what works for one person might not work for another. That's why, again, we kind of have various things out there that we can utilize. So the athletic trainer's role, particularly as it relates to analgesics and anesthetics. So make sure the patient understands the medication. So again, make sure that they understand how to store it, how to use it, any adverse effects. So we talked about some specific adverse effects. Again, that's probably some of the more prominent things to remember. Review all your treatment goals, and one of the things that's encouraged is using patient-rated outcome scales, because what this can tell you is if the person's truly getting better. So a lot of these outcome scales can let you know, is what they're doing working, and this would be utilized not only just even with medications, but even just with your treatment in general. Monitor their pain and response. So look at how pain affects their health-related quality of life. And again, for there to be a meaningful improvement, basically what they suggest is that there must be documented improvement in pain at function at least 30% compared to the start of treatment. Okay? So a decrease in pain intensity in the absence of improved function is not considered meaningful except in very limited circumstances. So in extreme circumstances, obviously that might not be the case, but that's really what we're looking for. Okay, be observant of signs of abuse or misuse. And the same will obviously go once we actually start talking about opioid medications. They're, in any instance, you want to make sure no medication is getting abused or misused. We'll expand on that more with the opioids, but still, patients could still abuse non-opioid analgesics and anesthetics. So particularly, like for instance, Tylenol, acetaminophen can be very damaging to the liver if taken too much. Even with some of these topical, anesthetics, things like the patches and things like that, they need to make sure that they're using those appropriately and that you're monitoring them for any adverse effects. And again, discuss the overall treatment plan. Make sure that they understand that there's other things that can potentially go into the treatment of their pain and how to best treat that. So in summary, again, pain management, it's a vital part of therapeutic intervention. Again, whenever we're treating an injury, one of our early goals is pretty much always to either reduce or eliminate pain. So that's something that's always going to be there. It definitely has a profound effect on quality of life. It's one of the first things, obviously, we notice when individuals get injured. So we want to make sure that we kind of do that. And we always talk about, so is pain the fifth vital sign when we're looking at treating a patient? So, we always talk about our vital signs and kind of, making sure that all those are normal for basic function, but we don't really talk about pain with those, but that's why we say, is pain the fifth vital sign? Because again, it's so critical in many things that we manage medically. Again, ATs often have frequent interaction with patients, so again, minimize patient uncertainty as much as possible. Again, have an understanding of the analgesics. Again, start slowly with over-the-counter medications before incorporating prescription meds when possible. So, do utilize over-the-counter medications. Try and see many times. Again, it's always good to start with something that's, maybe not as strong at first and see if it works. Because obviously then that could be a lot easier to manage. And then obviously if an over-the-counter solution isn't getting the patient where they genuinely getting the patient where they need to be at, then they may need to consider a prescription medication. Again, regularly monitor the patient, incorporate patient-reported outcomes, because again, this could kind of tell the patient, that they're getting better, and even possibly, discontinue the treatment or the medication that they're actually taking. And these are our objectives, which kind of outline what you need to know. So again, these would be utilized to organize and prepare for your exam.